Welcome to the Metabolic Link, a podcast that explores the common thread of metabolism in health and disease. This is where science meets society. Welcome to the Metabolic Link. Today, I am super excited to interview Dr. Kyle Gillett. He is a board-certified physician in family and obesity medicine, and he provides holistic, individualized care to his patients. His practice includes preventative, integrative, precision medicine using genotyping. And I would also add that he is an expert, has a high level of expertise in hormone and metabolic optimization. He's active in obesity medicine organizations and firmly believes that food is medicine and exercise is medicine. These are the two big levers that he pulls in his practice to get people on the path towards optimal metabolic health. Dr. Gillett describes the 6 pillars of health being exercise, diet, sleep, stress, sunlight, and spirit. And we'll add that he is an encyclopedia of knowledge. He really is. And we delve into a lot of different topics here. And I think he showcases that on this podcast on pharma-based therapies and nutrition-based therapies and also supplement-based therapies. His knowledge is very, very wide and it's very deep. And his background is family medicine, which you really need to know, have a very broad base of knowledge. And Dr. Gillett also enjoys, like I do here, time outdoors on the farm with his wife. He's got 2 sons and he's got 2 wolfhounds. We delve into so many different topics, and I'm so excited to share with you this episode where we talk about everything from ApoB levels, CGMs, a little bit. We talk about non-nutritive sweeteners, the gut microbiome, and we talk a little bit about hormone replacement therapy and different hormones that can be measured. And he delves into his 6 pillars of health and the importance of each one and how he approaches the 6 pillars with each of his patients and how to optimize it and personalize it to the patient. So once again, thank you for joining and welcome to the Metabolic Link. I hope you enjoy the podcast as much as I did. Thank you. Dr. Kyle Gillett, thank you so much for joining us on the Metabolic Link podcast. I have been following your work for the last year, and you got put on my radar, I think, by Justin Caviar, maybe, or you did a podcast with somebody and it caught my attention. And what really appealed to me was your depth and breadth of knowledge on so many different aspects. So I'm just going to intro your expertise to the listeners here who may not be familiar with you. Dr. Kyle Gillett is board certified in family and obesity medicine, and he provides holistic, individualized care to his patients, and his practice includes preventative, integrative, and precision medicine. And I would add hormone and also metabolic optimization to that. He is active in obesity medicine organizations and firmly believes that food is medicine and exercise is medicine. Dr. Gillett describes the 6 pillars of health being exercise, diet, sleep, stress, sunlight, and spirit. And we'll add that he is really an encyclopedia of knowledge on many different things, including outside of that, or integrated into that would be pharma-based and supplement-based therapies. And I've heard you talk extensively on that with an incredible background of knowledge. So as mentioned, your knowledge base is very wide and deep, and you practice family medicine. And I think I just Googled what gives you the most broadest, knowledge base in medicine. And I think family medicine came up because that you have to know everything when it comes to family medicine. I also read that you enjoy spending time outdoors. You have a farm, as I'm on a farm today, and with your wife and 2 sons and 2 wolfhounds. So one thing I wanted to ask kind of right out of the gate, again, and thank you for being here and taking time to share your expertise with our listeners here. What inspired you to focus on family and obesity medicine?
Yeah, so as people know, I'm from Kansas, and my father is what we call a full spectrum family physician, one of the last of the Mohicans, if you will. It used to be, as many people know, that people would go to medical school, get their MD, and be a GP or a general practitioner. And family practice was a residency of several years on top of that that was intended to be a specialty residency. And these days, 98% of family physicians, perhaps more, especially on the coasts, it's really not a specialty. They're just now the same as a GP used to be because of a delay in education. And yes, medical science has certainly progressed and there is more to learn. But the way that I saw this is the way that I saw it practiced in my area, full spectrum, anything from delivering a baby to doing end of life care and praying for your patient. So that's what I sought out. And I knew that I wanted to practice high quality medicine. And even by the time I was a teenager, just being exposed to the faith-based practice that my father had and that he still works for, I knew that it would need to be a unique model. That way there wasn't red tape in the way of patient care.
Mm-hmm. And that's really interesting background there. So what are the most common issues that you treat in your practice, and how do you specifically integrate personalized care into that? And if that's genotyping, or how do you integrate personalized care into your practice?
Yeah, the most common conditions are metabolic disease, cardiometabolic disease, I suppose I should say, and hormone pathology. So a good example of this is menopause. So slightly more than 50% of Americans will undergo menopause, or a hormonal pathology at some point in their life. Many individuals, both male and female, will want to conceive a child at some point in their life as well. And that is arguably also a hormonal condition. I wouldn't call it a pathology, certainly. Just like pregnancy is not a pathology, it's a natural state. But at the same time, there are many things that you can do that are well-based in evidence to lead to a more optimal outcome, or a better health span of the paternal side, maternal side, and the offspring as well. Mm-hmm. As far as the personalized component, I use the term individualized medicine. I didn't know it at the time, but there is another clinic, it's Mayo Clinic, that also has an individualized medicine clinic. And their clinic is truly a personalized medicine, or it has a genomic component. So a good example of this might be Lynch syndrome or Li-Fermini syndrome, BRCA, certain syndromes where perhaps an oncogene is turned on, or there is a strong predisposition to something, for example, cancer, neoplastic disease, and they treat the patient accordingly. But that's just an easy example or a microcosm of every single human that has different genotypes, which will very likely lead to different phenotypes. Parsing out the causation and the correlation is very difficult, because often things like polygenic risk scores do not have a lot of clinical significance. And making individual decisions, even for something like whether or not to test for an ApoE allele, and secondary to that, do you test for FOXO3s? Do you test for SHMOOS? Do you test for all these other things that may have clinical significance? And the answer is actually relatively simple. If it leads to a change in management, or it helps the patient understand their condition, which would lead to a change in management, even if that change is lifestyle modification, then it can be reasonable to test. But the way I see individualized medicine, which is think of a Venn diagram of three different things: your genotype and the nature and nurture, your individual goals, and then all possible health interventions, whether it's medications, supplements, or lifestyle interventions. The middle of those three circles would be individualized medicine. So the personalized genotyping, if you will, is just one small component, whereas the most forgotten component is the goal of the patient. Because when you're considering an intervention, it's a scale. You have the benefits on one side, the detriments on one side, and you do a process called shared decision making to help the patient make that decision.
Mm-hmm. So if you have genotyped the patient, how actionable is genotyping for nutritional supplement or even drug prescription? Common. I teach pharmacology and nutrition and physiology and neuroscience and various things. We talk about this in nutrition, and sort of the general consensus, and we did get nutrition as a mandatory course in our med school just recently. The general consensus is that like nutrigenomics is not quite there yet, but
Correct.
I know with drugs like warfarin and other things, what's your perspective? And when you have the patient's genotype, what can you give an example of like actionable things that you do? Just one example would be good in regards to using that information for metabolic health.
Yeah, pharmacogenomics is huge.
Yeah.
So pharmacogenomics is your body's response to a drug. Often it is the pharmacokinetic profile, or the P, you might hear pharmacists talk about PK data. That just means how your body metabolizes the drug and how it moves the drug, whether it's through liver clearance or whether it's through kidney clearance. That's the pharmacokinetic profile. And a lot of that is very closely caused by your genotypes. So there's a whole bunch of different tests that test a couple of these genes. And with clinical genomics, it's not to get off on too big of a rabbit trail, but a good analogy is SNPs, which are single nucleotide polymorphisms. That's like one letter and one word and one sentence and one paragraph of one chapter of one book of the encyclopedia of your genome. So you can have one normal looking word, but have other genes that are mutated that you don't test. Or even if you get full genome sequencing, it's not perfect. You have to have a certain depth to that sequencing. So just because someone has let's say an MTHFR polymorphism, it does not necessarily mean, they might have 3 of the 4 classic polymorphisms, but they might have other genes that are commonly not tested in most genetic profiles for the MTHFR gene, and they might not have significant issues with building up homocysteine or methylmalonic acid or methylating their B vitamins, as one example. Yeah. But certainly the more mutations you have or the more allele you have, there begins to be a stronger genotype to phenotype correlation, which means what genes you have and how well they align with what actually happens. And this part of the reason why this is so complicated is that's different for every single gene. It's not like there's a 50% penetrance of, and they call that clinical penetrance. Like if you have that gene, how likely you are to get this. Another, possibly even more so than pharmacogenetics. What's even more pertinent is certain types of mutations leading to cancer. We mentioned Lynch syndrome earlier. BRCA is another common one. Yeah. And you can pretty closely align what is likely to happen and take away a clinically significant endpoint, whether it's more screening or preventive lifestyle or preventive meds.
Okay. So we're kind of a little bit away from the day where we can make a nutritional prescription, but we can, B vitamins, methylated B vitamins, and sort of maybe gravitate towards are we at the point where we can gravitate towards more of a carbohydrate restricted diet, or maybe a diet that's more heavy in carbohydrates or fiber, or devoid of certain, say for example, and this kind of leads up to the next question. So I'll just kind of jump right into it. I have some friends that have impaired like phase 1 and phase 2 metabolism, impaired metabolic detoxification, maybe if in their words. So have you seen impaired, health associated with, and two individuals come to mind with impaired environmental toxins or metabolism and detoxification, whether it be glucuronidation or some other pathway, like in the liver, for example, where environmental toxins is significantly impacting the health of your patient, and not only like heavy metals, but maybe BPA or maybe glyphosate. I grew up on a farm 30, 35 years ago, was running the sprayer for Roundup, on our farm, and just exposed to a lot of different chemicals. So it's kind of like a selfish question, and if these could have long-term, consequences. But in your practice, is it blown up? You see so much buzz about this, and there's a lot of opinions about heavy metals and glyphosate and BPA. Is that something that's significantly impairing metabolic health in your practice? Do you see that?
Not so much as ultra processed foods, but it is a problem that I see relatively frequently in my practice, but that's also because of observer bias. If you're a specialist in,
Yeah.
and if you're known for doing functional medicine, as we are, then often the most difficult and recalcitrant cases will seek you out, keep having things happen. And a lot of times there's multiple pathologies, but I've certainly seen all the different things that you've discussed in my practice. I think that the general person that goes to that's perhaps interested in natural health and they want their physician to be more functionally minded, perhaps they've seen other healthcare providers that are not credentialed as an MD or a DO before. In general, unless they have a specific history or exposure risk, then things like chronic Lyme, heavy metal poisoning, glyphosate poisoning. Now, if they grew up like you and I did, homeschooled doing 4-H on the farm, spraying Roundup everywhere, then perhaps it's a different story. But for the average individual, it's not one of the main things that you would want to risk assess. The main things you want to risk assess is their metabolic health, their diet, their exercise, their sleep, and the 6 to 7 pillars.
Yeah. Okay. So generally speaking, then, that's really not a low hanging fruit at all of something that you'd want to test for. And have you actually ran a glyphosate test on someone? And is there like a commercially available kit that you would recommend for that? I'm just kind of thinking for myself selfishly, but I do get this question asked quite often that people are concerned about it, impacting their gut microbiome or other downstream effects of this.
Yeah, the testing for glyphosate or other toxicities is often secondary. So instead of testing specifically for glyphosate concentrations, which to my knowledge does not have clinical applicability, I haven't done it personally, which there might be, I just might not know about it yet. But instead, looking at the gut microbiome, looking at, for example, for mercury poisoning, yes, there's several good mercury tests, which occasionally you can do. Provoked testing is in general the gold standard, but often the first case is just seeing how your various coenzymes that have selenium as a cofactor, since mercury interferes with selenium cofactored coenzymes. A lot of times that's the first step, and then you can dig deeper. So I always tell people you can always dig deeper. Sometimes you do some damage as you dig, but just like a company that's digging in your front yard for something, they'll probably tell you, hey, there's a chance that we hit this power line. That's one of the risks of digging a 20-foot hole in your front yard. And then after that, we'll patch it up and it might take a bit of time. Just like that company would explain that risk, the healthcare provider should also explain the risk of slightly more intensive testing, but starting out with the low-hanging fruit, as you mentioned.
Yeah. Okay. Yeah, I did a metabolomics plus test by Genova Diagnostics, where you do the whole battery of things, saliva to urine to blood, and it was off the charts of bismuth, and I was like, where is that coming from? But I eat massive amounts of fish, and I had just gotten back from Dominican Republic. I mean, I was eating like 3 pounds of fish a day, so I thought it would kind of be it was a short time after that, so it'd be a good time to check heavy metals. And I did hair in addition to this too, and everything was very low. But the bismuth, I had taken Pepto-Bismol because I picked up something, I think, in Dominican Republic when I got back, and took a relatively small dose of Pepto-Bismol, and I was like off the charts in bismuth. And it took me a while to figure out kind of what that was, but it was kind of reassuring to me that the test picked it up, and it must be pretty sensitive because I just took like one dose of it a few days before. So I guess these tests can be helpful. Yeah.
Yeah, the tests can certainly be helpful. Another way to think about heavy metal testing in general is just like your body will sequester off or form granulomas around something like tuberculosis. It can, to some degree, do the same by it somewhat prevents heavy metal toxicity, including mercury, but other heavy metals, by limiting how much is in systemic absorption at one time. That's why when you provoke it with a chelator like DMSA or whatnot, then you will release it and often feel worse because you're transiently releasing more, whether it's stored intracellularly or whether it's walled off somewhere, or even whether it's in amalgam. Um,
Mm-hmm.
there is it's almost like if you have a abscess or a bacteria that's walled off, it's not systemic to some degree, and then you do a biopsy to look at it, then you can see it or cause a transient bacteremia. Maybe a better example would be if you have a lot of calculus, if you have a lot of tartar on the teeth, and then you get a really hardcore teeth cleaning, and that can also release bacteria throughout your system, which is not necessarily a bad thing, but it's something to remember when you're testing for things like that.
Oral health, yeah, for sure. Well, on the topic of testing, I have so many questions here. Let me kind of have a selfish question. I had a couple of friends of mine get the pre-nuvo test, and I wanted to gauge your experience and knowledge and kind of broad recommendation on the use of these full body MRI tests, and if it's something that one should consider if they're financially, willing to invest in that. Do you think they're helpful?
Yeah, they can be very helpful. Again, the Prenuvo is one of the examples that I was specifically thinking about, making the analogy about digging in your front yard. So when you get a Prenuvo, 98% of the time you find something. They might be what's called incidentalomas, but if you have the right patient that is on board with potentially finding an incidentaloma, and in fact, a lot of times when I tell people that they're a good candidate for a Prenuvo, I tell them it's not really a cancer screening test or even an aneurysm screening test or a tumor screening test or anything like that. Think of it as an early detection test. It's a commitment for at least 2 scans, because there's a very high likelihood that they'll recommend follow-up scans, recommend more follow-up scans and more follow-up scans. Yeah. So as long as they're willing to commit to that, and ideally have a clinician that can discuss the results longitudinally over time, that's the main thing. A lot of the other controversies about it, and I've spoken with Dr. Raj before. I believe he's the doc that was one of the founders of Prenuvo.
Yep.
He's a knowledgeable radiologist, MD, PhD, I believe. And I've talked to other radiologists that are more for and against it, but a lot of the way I see it is that the Prenuvo should be used as a individualized medicine tool, not necessarily, offered widely to every single man, woman, and child, but for the right person. The benefit of it outweighs than the harm of it, because the harm is basically what we discussed: the potential incidentalomas, things that would cause unnecessary anxiety. But for a lot of people, it lowers their anxiety, even if they find an incidentaloma, if they're expecting that result. So that's the way I see Prenuvos. If it can help more individuals than it is harming them, then it's a good intervention.
Okay. Yeah, that's good to know. I mean, like with blood work too, the earlier you start getting it longitudinally and looking at that, the same with the DEXA, to get DEXAs every couple years, which kind of I've been doing. But one thing I've learned, at least with the MRI, recently got one on my shoulder and an X-ray, you can't unsee an MRI. So once you see and the doctor points out to you that this looks like a gnarly mess in there, and I have a reverse Bankart tear, Hal-Sachs injury, fracture of the humeral head, a hematoma, and a couple other things going on after just like an injury. But I feel totally fine. I have some subluxation and some other cracking and popping going on, but I have zero pain. And I have to convince myself. I keep thinking about that MRI and what he was pointing out, and that's kind of weighing on, which kind of brings up another question. I'll ask you about PRP and BCP 157, but I'll leave that for later. But yeah, the MRI is a question that I've been sort of debating. And another hot topic in the field of metabolic health, which is quite maybe a little bit controversial in the context of ketogenic diets. Not so much in the ketogenic diet. This issue did not exist like 10, 12 years ago when I'd go to the American Epilepsy Society and we would have, the dietary symposium, which would talk about the special interest group with ketogenic diet in kids. It never really popped up this LDL, elevated LDL ApoB, which seems to be in some cases a hallmark characteristic in a particular phenotype that has been labeled the lean mass hyperresponder phenotype. So in this context, LDL and ApoB is quite high, 2 to 3 times higher, but you have a situation where your HDL is twice as high as your triglycerides. And, the rest of your metabolic health, cardiometabolic health biomarkers and, CMP, CBC in general is immaculate. So there's nothing wrong, except a tripling of your LDL and ApoB, which I'm not necessarily in that direct camp, but I have some variation of that, as do many, many people who email me. And I just wanted to know, to get your opinion on this, which I frequently ask people, what is your opinion of someone, and do we know, for example, do we know what an elevated ApoB would mean in the context of otherwise, perfect biomarkers? We don't, to my knowledge, we don't have long-term, but as a physician, how would you treat someone that's a lean mass hyperresponder?
Yeah, it's an excellent question, and one that we do deal with very frequently because it does seem to be a frequent phenotype. And I'd say I'd meet the phenotype myself as well. And I wish I had my lipoprotein block from, I think it's Thomas Dayspring that made those, because it helps explain things like particle sizes. But a lot of times when you have a high HDL as well, like you mentioned, yes, this person's probably exercising, but they also probably have a large particle size, because large particle size makes it harder to exit the circulation as well. So a lot of times you see those light, fluffy particles, or whatever the in vogue term for them is. It's just a large particle size, lipoproteins, even HDL. And the correlation with very high HDL does not alleviate all of my fears regarding high ApoB. And in the isolation of other risk factors like insulin resistance or high levels of acute phase reactants like CRP, it does significantly lower my risk for building up of atherosclerotic plaque. That being said, even newborn babies have atherosclerotic plaque. So in a lot of those individuals that are at higher risk, I get something like a CCTA, because they're probably not in old enough age categories where it's calcified. If you do a calcium score, it's probably going to be 0. 2 weeks ago, there was a 41-year-old male, and he was not on a ketogenic diet, but he had elevated, he did have a bit of metabolic syndrome, and he had elevated ApoB, and he had greater than 70% stenosis in his LAD with a calcium score of 0. So the uncalcified plaque can certainly be clinically significant. But in some genotypes, again, I'll bring up a genotype of ApoE4. Let's say there's an E4, and they have extremely elevated ApoB and high levels of lipid particles. I'd be concerned for building up of lipid particles in brain cells in that individual, rather than necessarily heart attacks and strokes. So I guess some of it's which endpoint is desired, but in those individuals, even if they don't have elevated acute phase reactants at that time, if there's somebody that travels a lot, they might get sick a lot, they have transiently elevated CRP, then are they planning to address ApoB just when CRP is high? And that's where shared decision making comes in, because there's no great evidence. Yes, there's an interesting study out of South Korea, I believe, but ages 20 to 40, or I think it was actually 19 to 39. And they had 2 huge groups of individuals, population study, probably a retrospective cohort, where they looked at the one study that was on lipid lowering therapy that also has a proven benefit to decrease atherosclerosis. And there was a benefit in the group that was on it. But at the end of the day, this should be individualized, because it's not a low harm intervention. Even if you add in something like a PCSK9 inhibitor, you also want to look at hormones in those individuals. Are they low on estrogen, especially estradiol, the strongest estrogen? You want to see if they have a high or a low lipoprotein little a. So you're just looking at every single risk factor and then weighing the interventions that they can do. But I would say, let's say that you take one of the lean mass hyperresponders, metabolically healthy, no autoimmune disease, for example, no rheumatologic disease, and then you compare it to an individual with diabetes that has a perfectly normal ApoB, much higher concern in the individual with uncontrolled diabetes.
Yeah. Yeah. So you got to factor in, the hazard ratio of, all these different biomarkers, and of course their fitness level and, blood pressure and things like that, body composition. So yeah, it's just multifactorial. We need some kind of, algorithm or metric where we can put all these variables in, and then some kind of AI system that could tell us what levers would be best to pull given the phenotype and the genotype. Maybe that's on the horizon. I don't know.
My colleague Taylor Martin, preventive medicine physician, trained at Hopkins. He's working on a similar project, and we have a long time to do it. It'll probably take a couple decades, but eventually we'll have a clinically validated tool. You can compare it against a biobank, just like a 10-year and lifetime ASCVD risk tool. And eventually we'll have a similar kind of like broad scope ASCVD risk assessment.
Factoring in genetics too and incorporating all that. Yeah. Well, I mean, with that in hand, one of the areas that we focus on in our lab right now is the metabolic control of epigenetic regulation. And it's specifically something called beta-hydroxybutyrylation, where the beta-hydroxybutyrate directly interacts with the histones and causes modifications. And it's more like a very nascent area of research. It's just developing. Only a few labs have really kind of shown this, but it's one of my PhD students' projects. So she's working on convincing me of that, the importance of that. But with that said, what are your general thoughts on sort of the metabolic control of epigenetic regulation from, DNA to histone modification? Do you think that there is, what I've talked to various people about is that when you follow a diet, for example, like a high carb diet, a ketogenic diet, there are a host of different changes that happen to your metabolism, like your enzyme systems. And there's kind of like a metabolic memory where you can kind of get off of the diet and get back on again. And then you adapt very quickly, almost like muscle memory, where you build up to a certain amount of strength and stop and jump back on again. So I've observed this, but I don't think it has been more or less like clinically characterized, but we kind of anecdotally know that this happens. And I'm assuming that there's a major epigenetic component into that. And just wondering I know it's kind of like a curveball question of what your thoughts on that would be.
Yeah, I really like the example of the beta-hydroxybutyrate. The example that I like to make behind correlations between diet and epigenetic shifts specifically is a study on pediatric obesity. They used a different type of butyrate, not a ketone butyrate, but a fatty acid chain butyrate.
Mm-hmm. Yeah.
And I forget which one. It wasn't sodium phenylbutyrate. That was the one in the ALS study, along with torsadile.
Yeah, bufenil. I think they use, you could just there is a sodium butyrate. It smells like crazy. We have some in the lab, but there's different types of butyrate, and they're both
butyrate bound
inhibitors.
Yeah, there's butyrate bound to glycerol. It's like tributyrate because glycerol has three places to bind the butyric acid. There's magnesium butyrate, there's calcium butyrate, but I forget the type of butyrate they use, but not that it matters. But anyway, they studied as one of the primary endpoints shifts in the gut microbiota, which I suppose makes sense. And there's even probiotics that are Eutericium that butyrate producing. And there's other sort of fatty acid postbiotic producing bacteria. But anyway, the point is that they studied the body composition, and in these pediatric patients, they still gained some lean body mass. You'd expect them to be growing. They're in early adolescence, and they lost body fat. And they also had positive shifts in the gut microbiome. And you would think that with that butyrate supplement, that there would also be significant epigenetic changes. But even if they had that as a secondary endpoint of the study, be very difficult. And the devil's advocate, which, this is a legitimate devil's advocate position, would say, well, they had those positive epigenetic shifts because of improved body composition or because of improved metabolic health. But it's probably not just that. There likely is some direct link between gut microbiota and those shifts. There's another interesting probiotic called Lactococcus lactis that it has an effect on plasmid DNA, on I believe some sort of a dendritic cell, so neurologically origin cell in the gut as well. So that's another one, gut-brain axis, another two, gut inflammatory axis, but also I could see non-genomic effects, if you will, of the shifts in the gut microbiome and the epigenetic changes. So there's multiple mechanisms. Everyone's looking for this one, like the tug of rope between your diet and your epigenome, and and I think it's great to study things like beta hydroxybutyrate and how it could acetylate or deacetylate, or how the histone proteins move. But at the end of the day, I think it's going to be a dozen or more different ropes all pulling and contributing to that process.
Yeah. Yeah. And I think, in some camps, there's like a stigma or just a trend towards no fiber diet, whether it be completely carnivore, which admittedly, I think can help some people, and it is a type of elimination diet. But you kind of, even it's mostly, it's data that's not fully backed up and has a lot of caveats, but fiber. There's a lot of data to suggest that fiber, by feeding the microbiome and increasing, for example, soluble fiber helping to produce short chain fatty acids like butyrate. And that has it's a fuel for the colonocyte. It gets in circulation, and it has some epigenetic effects. And but also I was reading, our lab has been studying non-nutritive sweeteners, saccharin, aspartame, sucralose. We're also very interested in allulose. And I was reading a couple papers on allulose, how it influences the microbiome, specifically increasing things like akkermansia, which can increase the mucus layer and help protect the gut. And some papers to suggest that allulose may be working through a GLP-1 agonist effect. So in regards to appetite suppression and things like that. And it's very interesting. So I think you have a potential sugar substitute, not a non-nutritive sweetener. I guess it's not in that camp, but I think you have some of these things emerging, and wanted to, I know it's another polarizing topic for people. And, I posted something with the CEO of Moffitt, Dr. Patrick Hugh. We had a little talk about aspartame and the characterization of a possible, carcinogen. What's your general thoughts, your opinion on non-nutritive sweeteners, and then some of these sugar alternatives like allulose and their potential as a functional food?
Yeah, like any other dietary component, there's a lot of positives and negatives. Even fiber, like you mentioned, I can't deny the phenotype of the low BMI young female with autoimmune disease that gets significantly better when they're on a no fiber, mostly protein diet. So it is interesting. But yeah, for the general population, the average American who has metabolic syndrome, because the average American does have metabolic syndrome, for almost any non-nutritive sweetener, while they're improving that metabolic syndrome, the benefit of the non-nutritive sweetener outweighs the risk of it for almost all of them. However, they're certainly not without downside. And I've also mentioned, I guess I should plug my podcast. We have a all about carbs, all about fat, all about protein, and I think an all about non-nutritive sweetener podcast, or maybe that's in the carbs. But we discussed that even things like allulose, I believe there's 0.25 kcals or cals per gram in allulose. So a lot of them have a tiny bit of caloric content. The old school fiber yum or VitaFiber that can't be called fiber anymore, that obviously also has calories as well, much more than allulose. And allulose does tend to be one of my favorites. a lot of things do feed akkermansia. I believe psyllium also has, even like, old school
Yeah.
tiny bit of psyllium, which most people take too much of, does have, it does feed akkermansia as well. But the dose makes the poison, and the same is true with sugar and with fiber and with non-nutritive sweeteners. Some of them that people think as like alternative sugars have just as many calories as sugar, like monk fruit. And then some of them are indeed very low calorie, like the
monk fruit. So monk fruit has as much calories as sugar, but the amount, it's so potent. So it's like by gram amount you're talking about. Yeah.
Yeah. You'll probably, if you're looking for the same amount of sweetness, you'll consume a lot less monk fruit, but it certainly has more calories than allulose. It's not I wouldn't consider it, I don't even think it's considered non-nutritive. It's
in a weird category.
Nutritive sweetener. Yeah. I'd put it more along the lines with isos, like the old school Vitafiber.
Yeah, iso oligo maltosaccharide or something, IMOs or something like
those,
that.
Yeah, those are the ones.
Yeah. Okay, very interesting. So allulose, I mean, I got papers. It's like a calorie restriction mimetic. It's like increases akkermansia. It's got GLP-1. It seems like a miracle. Although, if I have too much, I get some bloating associated. So I think but I see a lot of potential in this, and I have not been, only recently did I kind of take a rabbit hole dive into the literature on this. So, okay. So I have a number of questions here in kind of delving down the hormone route for a couple, and then we'll jump to your pillars. But topical for hair loss, topical finasteride, minoxidil, red light as a combination for hair loss. Asking for a friend, right? So the impact. The combination of these things kind of used together, and if there's any kind of synergy, and also if your thoughts on topical finasteride impacting blood levels of DHT, and if that could be a concern.
Yeah, those are all reasonable interventions. Topical finasteride is tolerated better than systemic finasteride. However, for sure, it does go systemic. Finasteride and dutasteride are both relatively lipophilic particles. Dutasteride is even more lipophilic. Finasteride is a smaller particle than dutasteride. So with with the dose of topical finasteride that you would want for pretty solid efficacy, you'll probably see a decrease of systemic DHT by about 30%. But the way I think about DHT is I think about it in 4 different containers. You have your systemic DHT in your blood. That's like the DHT in your pipes, the plumbing in your house. It's the DHT in your pipes. Then you have 3 different sets of rooms. One set of room has mostly type 1, 5-alpha reductase, which is the enzyme that converts testosterone to DHT. And then you have room number 2 that has mostly type 2, pubic skin or penile, scrotal, labial skin, etc. That would be mostly type 2, and then mostly type 3. Finasteride is mostly type 2, although it does have some receptor affinity, some enzymatic affinity for both type 1 and type 3 as well, mostly type 1, less type 3. And then dutasteride is all 3, but of the 3, it is by far the least of type 2. So I think of finasteride and dutasteride as opposite medications. Dutasteride does affect most people call it intratesticular testosterone, but it's really just intratesticular androgenic signaling, which causes a positive feedback mechanism for more quality sperm and more sperm production. So long story short, topical finasteride and even topical dutasteride at a high enough dose will go systemic and be metabolized relatively quickly, but are much better tolerated than oral finasteride and dutasteride. Well, oral finasteride with a high enough testosterone, there's no such thing as a dutasteride syndrome. And oral dutasteride is extremely well tolerated when dosed appropriately, something like 1 capsule once a week. But you don't want to be on it within about 6 months of fertility. The minoxidil works actually a bit better if you take it orally, but it goes systemic if you take it topically as well. It's a prodrug, so minoxidil sulfate is the active compound, and depending on your SULT 1A1, then you can sulfate it more or less. Microneedling definitely helps the minoxidil efficacy a lot. Red light therapy it's promising, good theoretical benefit, But anything that causes even more microtrauma or more heat is probably going to work even better than red light therapy. If you have a thinner scalp and the mitochondria are in worse condition, red light therapy probably works a bit better. Otherwise, you're probably much better off doing something like microneedling, or even a lot of the PRP studies that you look at. They do saline, and even when you just do saline and inject 50 or 60 times, it works pretty well without PRP at all, but it works even better when you do PRP. But yeah, the micro trauma definitely works a lot. Even if you just shaved your head and got a couple really severe sunburns, that would probably also help a little bit. I do not recommend that method, but that's just to make the point. As I've talked about on my podcast, my regimen when I'm not on a testicular health phase and I'm not trying to like bank sperm or conceive a child or anything, is oral dutasteride, but I have taken oral finasteride. I've not taken minoxidil yet, but I've also microneedled quite a bit, and I've tried PRP. And I'm pretty much a hyper responder to everything that I try, fortunately, for several reasons. But for someone who does not have any desire for fertility or conceiving within about 6 months, some sort of growth agonist like minoxidil or PRP, and some sort of anti-androgen like topical dutasteride, or in some cases topical finasteride, but probably topical dutasteride or even oral dutasteride is going to be your biggest bang for the buck, best long-term regimen.
Okay. Yeah. So, I mean, it's kind of using those minoxidil, topical finasteride, red light therapy, and then Nizoral or ketoconazole shampoo like twice a week or something like that. That's been kind of, I feel like it could be where, although when I did not wear a hat outside and I did get sunburn on the head, I noticed that my hairs were falling out, but I don't know if that's just like an acute response. But yeah, of course, the blood vessels will be stimulated. It's red, and you'll have capillary dilation. That could maybe help with that. Another hormone kind of related question. I've communicated with a few guys, and 2 or 3 of them had tried testosterone replacement therapy. They were young, and they had before and after blood work, and I'm not sure what these clinics use for dosing. I think it was a low end of maybe 100 milligrams per week or something like that, like given twice a week. But their testosterone went down. So they went into it with like 700-800 or something like that. And after, TRT therapy, whatever dosing they were used, and it was on the lower end of the spectrum, their testosterone actually went down. They got full blood work. This is 2 people, one more recently, and I gave some just suggestions and advice, and they went and redid the blood work. But I noticed the LH was suppressed pretty significantly. The FSH was suppressed pretty significantly. And my recommendation, and not a recommendation, not giving medical advice, but just based on my experience, for getting a little boost of testosterone was DHEA to, get off that and just try DHEA, just especially if it's low normal, and bring it up to normal. And that's, to my knowledge, their testosterone is maybe after some Clomid or N-clomiphene, I think, back to normal, back to high end of normal, and they're using DHEA too. And that adds, for me, what I've noticed is that can get me from like a 400 to a 550 or something like that. If I, measure an hour after 50 or 100 milligrams of DHEA or something like that. And just thought that this could be like a pre-TRT protocol. And then you could, potentially, if your DHEA is low, use a low dose of something off the shelf, of course, or commercially available. But wanted to get your thoughts on sort of this idea. And one thing about DHEA is that it doesn't suppress LH, or at least if it's pulsed in the morning, there's no suppression of LH or FSH. Although personally, I did see my FSH is high normal and my LH is right in the middle of normal. And I've been taking DHEA for almost like 8 years now and don't see any kind of suppression. But I have seen, and I've done blood work at least a half dozen times, with and without, I see a consistent 20% increase in testosterone. And just wanted to get your thoughts on this kind of little my own side experiment thing and doing.
Yeah, for the right patient, it can be a great intervention. especially if the goal of TRT is to raise estradiol. It can raise testosterone to some degree, but often raises estradiol disproportionately much, which as long as your estradiol is not too high. So if you're pretty metabolically healthy and lean, like you and I are, then it can be a great addition. The leaner you are, the less you're going to aromatize, the less of your DHEA is going to eventually convert to estradiol. So that makes you a better DHEA candidate. I've mentioned before that I used to be on DHEA. That was one of the first supplements that I took along with creatine when I was in residency. I knew that I had varicocele and atrophy, as I've talked about. And later on, I went to do HCG monotherapy, which I've also talked about, but is even more helpful for my chronically low deficient estradiol levels, always 5 or lower. They've always been very low. So I was also definitely a great responder to DHEA. But for the average American, DHEA is probably not a great addition because so much of it, they'll aromatize so much. The average person's body fat is just so high. But I do like DHEA as an intervention a lot. There's a huge variation in DHEA levels. Yes, in older ages, there tends to be an adrenopause to some degree, and ACTH does stimulate production of DHEA from the zona reticularis and also cortisol. So it's kind of interesting that the same hormone produces a glucocorticoid and an androgen from the same gland, but and there is some degree of negative and positive feedback inhibition between the two. But I think that it is a great addition if you tend to have lower baseline DHEA and or lower baseline estradiol. So the perfect candidate would be someone with a starting DHEA under 100 and a starting estradiol under 10.
Okay. Yeah. My estrogen's always on the higher end of normal within normal range. And I think when I take DHEA, so that makes sense. And when I don't take it's on the low end of normal. So I do see that bump up. One other hormone question, and we're going to get to your 6 pillars. I take melatonin at night, but not for sleep really. I just take it for some of the other benefits that it has for brain function and Alzheimer's. Like I feel like a lot of benefits to melatonin. Would melatonin potentially suppress other hormones? In particular, I'm thinking maybe cortisol, because I've measured cortisol blood, but mostly I do salivary cortisol, and I'm kind of like a low end of normal, but I've always taken melatonin at night. So I want to repeat this without taking melatonin. Is there anything in your mind that could cause a suppression of the morning cortisol with a nighttime melatonin?
Yeah. So if I remember right, melatonin has 3 main receptors. Meds like Rosarim are most active and agonist at the first 2 receptors. Melatonin, of course, is an agonist at all 3 receptors. And I believe the third receptor is the most active on the hypothalamic pituitary, either adrenal or gonadal axis. However, it could be that DHEA is most likely what is modulating your ACTH most throughout the day. And a DHEA sulfate is a better long-term measure of DHEA. DHEA sulfate also tends to tell you if your DHEA came from the adrenals or not. So perhaps your DHEA supplement's not driving DHEA sulfate as much. I think about half to 2/3 is converted to DHEA sulfate. So it's still the best long-term measure, just like A1C is a better long-term measure of glucose levels than one single fasting blood glucose. But not to rabbit trail too much, perhaps the DHEA is affecting your cortisol a bit. Melatonin does have a lot of benefits other than sleep. And one of the, I'd say like dark horse potential future causes that I see it being used a lot in is in kids after adrenarche, so after their adrenals have kicked in, at high risk of precocious puberty. I bet we'll be using a lot more melatonin and also a lot more, hopefully, lifestyle intervention to decrease leptin resistance, to decrease body fat, to put off precocious puberty rather than essentially chemical castration of Lupron, things that we used to use very often. But for the right person, I think that a reasonable dose of melatonin, which depending on your genetics can vary anywhere from 1 milligram to 5 milligrams. For some people, even more than that, especially if they're on a very quick release melatonin, can be very helpful.
Very interesting. So, two quick questions following up. Any potential issues that you see with taking up to 5 milligrams of melatonin every day? I've never pretty much not taken it. Sometimes I forget it, but I still fall asleep the same and I still sleep. It doesn't seem to impact my sleep much. And the second, I know cancer patients, I've been in contact with them, they're taking 3 to 5 grams, 3,000 milligrams, 3,000 milligrams. They're literally like buying it bulk powder. And I was fascinated with, what is this? Obviously, you're just saturating the receptor. But, the feedback is like they feel great. It makes them calm. They have no subjective cognitive, suppression of energy or sleepiness throughout the day, which I find kind of fascinating at 3 to 5 grams per day. So any thoughts on the person who uses melatonin 5 to 10 milligrams a day every day?
Yeah, 5 milligrams a day for the average adult. As long as they're not a slow metabolizer. And if you are, then you would figure that out early. Just like other hormones, androgens, estrogens, if you go from a really high estrogen state to nothing, then you'll feel it. But if you go from an extremely high estrogen state to a fairly high estrogen state, then you have desensitization at the receptor level. And the same thing is true of melatonin, as you mentioned. But for the average individual that's an adult, I'd say a safer thing. And the other thing with melatonin, you want to know which supplement you're using. So you want to use, I'm a physician, so I'm biased. I would just prescribe it to a pharmacy and use a reputable pharmacy. Even among pharmacies, especially compounding pharmacies, there's a lot of heterogeneity. So in some cases, I would trust a supplement brand that does really good third-party testing, post it on their website. Maybe they even post batch and lot testing to where you can look up the actual HPLC data or whatnot from your specific batch of supplements. I might trust that over a compounding pharmacy that I'm not familiar with. So, so assuming that your melatonin says what it is, I'd say 1 to 5 milligrams would be a good starting dose if you're not under the care of a physician that's telling you to mega dose it for off-label cancer therapy, for example.
Okay, good to know. So let's transition to your 6 pillars of health and exercise being the first one. And just wanted to know kind of if you, as a practicing physician, for someone that comes in and I'm just thinking, my parents, for example, like they've never exercised, but they're active. And, if you look at people in the blue zone, to my knowledge, they don't do like purposeful exercise, but they're active. Right. Yeah. So how do you approach exercise being a really important pillar for someone who's never exercised? And do you just try to do a lifestyle design where they incorporate physical activity into their routine?
Yeah, the way that I describe this is a movement pastime to last a lifetime. So there's a lot of different movement patterns that you could do. Yes, ideally, this would incorporate some degree of cardiovascular training where you're at least getting into, an aerobic zone. And ideally, it would incorporate some degree of resistance training. But like you mentioned, this can be built into your lifestyle. If you do manual labor and you walk to and from your place of work and you're in a nice enough area where you can, let's say you live in like Costa Rica or, but then again, isn't Iceland a blue zone too? So the blue zones, it's kind of hard there's probably different reasons why different blue zones are blue, right? But if you're thinking about your classic one or Okinawa, then there's not a whole lot of gyms in those areas. There's not a whole lot of treadmills. But people are definitely moving. So that's how I think about it. Yeah. And depending on your genetics, an exercise prescription might be very reasonable. If you have a very strong family history of osteoporosis and let's say hormones are contraindicated and your phenotype looks like you're very high risk of developing osteoporosis, then specifically resistance training with axial loading would be you need to add that in. It's the best intervention that could help more than any other biologic, more than taking whatever osteoporosis injections that your doctor wanted. It's going to be more helpful. So sometimes you need a bit more than an active lifestyle.
Mm-hmm. Yeah, I saw kids, I think Haiti or Nicaragua, and they're carrying like a 5-gallon bucket full of water on their head and just walking and they were just like so young. I mean, and they're like in perfect health, like shiny white teeth, like pretty muscular and fit. It's just amazing. I mean, the bone density that they're building.
Yep.
Okay, so with exercise, yeah, it's going to be highly variable. But with diet, if you have the average person coming in, like what are some low-hanging fruit sort of suggestions that you could make for the average person in regards to diet? And another thing I want to kind of touch on is like gut dysbiosis and intestinal permeability, which seems to be a very, very much more common now than it has been, at least when I was growing up. And just maybe touch on that how you assess that.
Yeah. So as far as the ideal diet, you want a diet that you can adhere to. So this is a long-term diet. It's not really a diet at all. It's just a habit of eating things that are mostly whole foods. 80-20 rule would be reasonable. 80% of the things that you eat are healthy, and then 20% of the things that you eat, maybe you have some processed or even some ultra processed food. I think that's very reasonable to maintain your quality of life, some balance where you're not just focused on health. So the average person could probably consume more foods of a low caloric density and high nutrient density. Those just happen to be whole foods. And I do think that the average person can figure out how to have that movement pastime to last a lifetime, so that they do not have to do any long-term, very low-calorie dieting. And when they do, doing so under the course of a healthcare professional would be very reasonable, just because if they don't, they have a 98% chance of gaining the weight back if they just try to do it on their own without any other lifestyle change. So obviously, if there's a very obvious change where you're not moving at all and you find a exercise that you love to do, then that would be a different case scenario. But then if you're exercising a lot, you're probably not having a very low calorie diet, because then you're not going to feel great. So that's a bit of a rabbit trail to go into the second part of the question about the gut dysbiosis. A lot of that is related to what you mentioned before. You get on this pattern of low fiber in childhood, lots of C-sections. There's all these contributors, high antibiotic use. You're killing off your good microbiome. I think of your gut like a combined aquarium terrarium. It's contiguous with the caves of your mucous membranes, orally, pelvically. It's also has crosstalk with your skin as well. And the microbiome is passed down. People are probably familiar with, a toilet flushes or a door closes and all these microbes go onto your skin and your eye, and you meet someone and you shake hands and you reflexively touch the mucous membrane of your eye or your nose after that, and spread microbiota like that. So all these contributing causes, but most of the most important causes are dietary changes, especially ultra processed foods, less fiber early in childhood, and then the high level of antibiotic use, which obviously there's benefits to that as well. Those two have caused this die out of the good microbiota in general of your aquarium terrarium. And when that happens, you're going to have the bad fish that can more easily take up residence.
Mm-hmm. What are your thoughts on hydrogen peroxide-based mouthwash? And is disrupting the oral microbiome, for example, with maybe sugar-free gum or like a nicotine lozenge, which a lot of people are doing, or just mouthwash? So a number of different variables, or chewing tobacco, which is pretty big out here in Florida. Are these things impacting gut microbiome? I don't think a lot of people have thought, but I presented at the Oral and Systemic Health Symposium a while back, and I was really blown away by the level of science that suggests the oral microbiome really kind of, calls the shots when it comes to being a major influence on your gut microbiome. So wanted to get your thoughts on that.
Yeah, certainly so. So both the oral microbiome and the upper gut microbiome, basically just H. pylori in your stomach, have a lot of crosstalk with gut microbiota distally. So in the intestine, small intestine and large intestine. And the lower your titers of H. pylori, so somebody who's been on antibiotics that would otherwise eradicate H. pylori, even if they never knew they had it, they are much more likely to develop Crohn's disease, ulcerative colitis, because there does seem to be a lot of crosstalk between the upper and lower microbiome. I've posted before about the potentially protective effect of very low titers of non-virulent strains of H. pylori. And the same is true of many oral microbiota, crowding out strep. I know there's some good evidence that some things like xylitol can help crowd out strep mutans. I'm certainly not a fan of making the oral mucosa a sterile environment. I don't think that that's a great idea, especially not chronically. Good dental health. And again, I just mentioned like the cleaning off the calculus in your teeth, which is the really hard plaques that you can't get off with the toothbrush. You got to scrape it physically or scrape it with a water jet. Then a podcast. My brother, Grant Gillett, a dentist, he's done the Gillett Health podcast before. And my friend, Chris Strandberg, he's a dentist that works for Waterpik and a oral microbiome testing service called Bristle. There's a lot, you can dig into it quite a bit, but just like with metabolic health, your low-hanging fruit is dietary changes and good dental health.
Yeah. The last thing on the diet question, when it comes to permeability of the gut, there's a couple different tests out there. One is I think a PEG 400 test. Are you familiar with these tests that are being used for intestinal permeability, and are they something that people should consider when testing different interventions to repair the gut? There's a group, I think Paleomedicina, that's in Hungary, that uses this, and using a Paleolithic ketogenic diet, they've actually had remarkable success, based on some of the case studies they've published. So
yeah, I think that therapies like that are extremely promising, and ideally, once they have a bit more evidence, should be first-line therapies, rather than just mega dosing with glutamine, which is kind of like the reflexive functional protocol now. Yeah. Although now the reflexive functional protocol, there's a peptide that is basically like a glutamine derived peptide. I think it's just 3 amino acids from, I believe it's actually derived from alpha melanocyte stimulating hormone, just the 3 terminal amino acids on the end of that, because it doesn't affect the glutamate pathway. But probably I'd say for most cases, if you have a really high eosinophilic activation protein or really high calprotectin or really high zonulin, things like these, then the first thing would just be ensuring that you don't have an inflammatory bowel disease like Crohn's or a chronic infection. And the other thing to look at, I've always been curious how various bioavailability upregulators like black pepper fruit extract affect tight junctions. So, and I've dug into this a bit, and I couldn't find any great evidence behind basically editorial articles of people theorizing similar things one way or another. There's kind of 2 camps that really like that or really don't like that, but there's probably a dose makes the poison with that. But I'd say for the average person, the biopurine or the black pepper fruit extract, having that in every single supplement that you ever take is probably not the ideal situation, especially if you struggle with leaky gut to begin with. So I guess that's kind of how I think about it. There's not really a go-to medical therapy. Dietary changes and working with a dietitian, whether it's a Paleolithic ketogenic diet or a similar diet, it's probably true that if you find a diet that you're most likely to adhere to in the long run, if it's not a ketogenic diet, then maybe not shoehorning everybody into that. But for a lot of people, it's ideal first-line intervention.
Mm-hmm. Yeah. Well, you talked about IBD, but with IBS, I know I teach the GI section in med physiology, and there's a bidirectional comorbidity between if you have a psychiatric disorder and IBS, and it's kind of interesting how stress could, in ways that we don't really know, actually impact intestinal permeability and gut
Hmm.
function. And I think that's a whole nother frontier that needs further investigation. So sleep is another, major thing. And I know missing one night of sleep, I think I saw a recent study, can impact intestinal permeability and gut microbiome and
Yep.
everything. I guess it's not surprising, but yeah, it's just, another fact. Well, it's your third pillar here. So what are the sort of the short version take home message that you're going to, and I think that ties in good with the fifth, also sunlight. So I like to
Yep.
think about sleep. For me, I mean, sunlight, being in Florida, is just like a mandatory thing. I just get out first thing in the morning to let the cows out and
Yeah.
get my dose of sunshine.
Yeah, absolutely. I think of it as both quality and quantity sleep. So you can't just fulfill your sleep pillar of health by having people on benzodiazepines like Xanax or Klonopin every single night. They'll get some sleep, but it is probably not going to be quality sleep. But this has to do with a lot about hormonal function, both sunlight and sleep, because as we've alluded to earlier, it has a lot to do with your circadian rhythm, when you secrete melatonin, when you don't. And some of that just depends on age too, like growth hormone and testosterone. Melatonin secretion tends to go down over age.
Mhm.
Um, Probably not directly correlated with pineal calcification or whatnot, but for a multitude of reasons. But the good REM sleep in particular, that along with your zone 2 cardio, those are the two things that are most important for the health of your mitochondria as you age. Not just health in the mitochondria in the muscles, but also in brain tissue. So that's the way I think of sleep as a pillar of health. Sunlight, maybe it could have been completely combined with sleep, but I also just think of this as that humans are in this artificial indoor environment. When being outdoors, we're exposed naturally to cold exposure in the morning. You go outside and it's blasting cold in your face. You're going to get your endorphins and your adrenergic, you're going to get your dopamine and your noradrenaline that way. Whereas now, I guess, our technology has gotten so good that we can use cold dunks and sauna and whatnot to get our element exposure instead.
Yeah. So, I'm at a window looking out over kind of a field here, farm. And if I'm at a window, if I wake up in the morning, I don't have time to, go outside and I have to start my workday early or whatever. Am I getting the sunlight? I know we're replacing our windows soon and going to it's going to be blocking the infrared spectrum and different, am I getting the same quality of sun and light from through a window from looking out?
Yeah. I'm not sure on this question. I know Huberman's talked about this before.
Yeah.
I I get it doesn't hurt to be outside. You're getting other
Yeah.
things by being outside, like cold
Sure.
exposure, the wind, potentially even grounding.
Yeah.
When I was in residency and even some in med school, I really liked the effect of longboarding, basically like a type of skateboard. I lived very near the hospital and
Mhm.
I'd longboard there almost every day, unless it was pouring rain.
Mhm.
And I definitely got a different effect from the wind in my face and hearing the animals, hearing the birds cheep, usually early in the morning or late at night if you're going in
Yeah.
for a night shift. And the effect is definitely different, but I don't know if it's due to the sunlight. But I'd say personally, probably half the time when, um, especially if it is in the winter and if my dogs are not up, then I'm less likely to go outside for my morning light, and I just look through uh, the window to the east.
Yeah. In regards to sunlight, so a few days ago I was outside too much, which I tend to do, just working on the weekends, and I got a sunburn. And the next day I had to be outside again to do work, and I didn't want to wear a shirt, so I put on sunscreen. So, any concerns with the use of sunscreen
The way I
from?
think of sunscreen is um, obviously avoiding sunburn without sunscreen is probably
Yeah.
ideal. If you're going to use it a whole lot, then a barrier sunscreen like a zinc based or zinc
Zinc based.
oxide based
Mhm.
sunscreen is reasonable, which of course you can't rub in all the way. But intermittent use of other sunscreen products from time to time, even your usual one over the shelf, a lot of times the benefit likely outweighs the harm. Personally, if I'm expecting like hours and hours, like let's say I'm going to the beach in Tampa for a wedding or whatnot, or a conference, I'll probably put the non-barrier sunscreen, or like the toxic chemical sunscreen on my nose and on the tops of my ears, because if I get a basal or a squamous, those are parts that are really not fun to have cut out. The rest of them, yes, it's not ideal, and you still want to avoid a sunscreen, but I'll probably use a barrier sunscreen that does not work as well on those parts. Mm-hmm. But yeah, there's definitely a rationale behind being able to have a little bit of a base tan, because you're significantly more resilient to sunburns. Melanomas are most related to really severe sunburns, whereas basal and squamous, which are usually locally invasive, that can still be very serious locally, are more related to cumulative sun exposure.
Mm-hmm. So stress is one we kind of skipped over, but it kind of ties into a group of people that I communicate quite often with: special operations forces, law enforcement, EMT, firefighters. What are your tips for shift workers who are under stress, but they also have the compounded problem of basically, being up all night and, not getting the sunlight in the morning. So you have sleep, stress, sunlight, dysfunction there. So, I had several emails about this, and I gave my recommendations, but what would your recommendation for where it's a mandatory kind of having to work this third shift?
Yeah, this is a tough situation, which I've been in.
Try not to be
personally.
in it.
Yeah, I try not to be in it, especially anymore, but I've certainly been in this situation a lot in my past through medical school and residency. But yeah, and that's also between when I had my first son and also was on mostly night shifts. That's when I gained, 25 or 30 pounds of excess body fat too, without even realizing it, just distributed over my frame. Yeah, anyway, that was definitely a bit of a shock. So it is hard to do that, but it's where you're especially cognizant in all of your other lifestyle factors. There's a lot of strategies that help you have improved sleep. Occasionally, I'll use things like Rosarim, which is a melatonin agonist, over melatonin. Some people can tolerate that better, especially if they're not able to tolerate melatonin. Some of them that cannot stay awake, that are napping all the time, it's going to affect their sleep latency and also potentially their sleep onset. In those cases, maybe you think about a low dose of modafinil, which can be a touch histaminergic in some people. Sometimes I just do something like 50 mgs of modafinil and 500 mgs of quercetin to help with the mast cell effects of modafinil. Yeah. Mm-hmm. So that can be a reasonable response from like a pharmaceutical intervention. And then frequent walks throughout the shift can help a lot. Obviously, depending on your profession, you might not be able to do stairs in the hospital, but that's what I tried to do. Every 2 hours, go up and down the stairs, and then smaller meals. So especially avoiding having a large meal and then sitting in the same couch for several hours. That can be something that is very difficult. And of course, there's some professions where you do 24-hour shifts. So you do have to try to fit in some sort of a rest here or there. Other things like non-sleep deep rest can be helpful. But depending on the profession, the stress management of that, your cortisol rhythm is obviously going to be off. So trying to help that situation feel good, trying to learn to enjoy it. Just like you can learn to enjoy the pain of lifting a heavy weight in a gym, to some degree, you can learn to enjoy the pain of a high stress situation that you're able to succeed in.
Yeah. So you mentioned like the go-to drug for night shift workers or maybe special operations is modafinil. And you mentioned maybe there's a histaminergic or histamine mode of action with that. And histamines from a neuroscience is a stimulatory neurotransmitter. So if one was to take an antihistamine, for example, for, allergies or something like that, would that block the effects of modafinil? So diphenhydramine is like lipophilic, right? So that gets into the brain and that makes you kind of groggy. And then the other ones that are not lipophilic, are less, less sedating. So that just occurred to me when you mentioned the histamine. I didn't know that
Yep.
modafinil works through histamine. Yeah.
Yep. Only some of the mechanism. Modafinil is the rhodiola of
Oh.
medications. Multiple mechanisms of action.
Uh-huh.
We know that it works, but the mechanism of action is not well characterized. But it's also likely orexigenic. There's 2 orexin receptors in the hypothalamus. There's 3 histamine receptors. In fact, one of the newest somnolence shift work meds is Wakix, Wakix, or pitolisant, which is a pure histamine 3 receptor agonist. Diphenhydramine or Benadryl, and a lot of these like first generation drowsy antihistamines also bind the 3rd histamine receptor. So you'd think that diphenhydramine would block some of modafinil's action, but not all of it. I would certainly wouldn't recommend the 2 together. Not that they'd be contraindicated, just because there'd be that interaction. You wouldn't be getting the benefit. Mm-hmm. There's other medications for shift work that are not related to modafinil or armodafinil, which is its prodrug. Mm-hmm. For example, Sunosi is one, and that one is a dopamine reuptake inhibitor, and also partly a norepinephrine reuptake inhibitor, but it's different than bupropion because it has that longer acting dopaminergic action, whereas bupropion is rapidly metabolized to hydroxybupropion. So bupropion is also kind of a prodrug, but there's a lot of actions. Modafinil is just a good go-to, just like rhodiola, even though it doesn't have a well-defined mechanism of action. And as much as I love mechanism of action, we just know that it works. It's probably partly adrenergic, partly orexigenic, partly histaminergic.
Yeah, very interesting. Again, you're like an encyclopedia of things, so I'm learning this stuff all the time. So the last pillar here is spirit, and you're pretty open with your faith, your Christian faith, and I put believer, I think, on my profile. Just sometimes faith is kind of like a debate between people, almost like diet. There's different camps, right? But I was wondering, do you have a spiritual prescription that you give people? And for people maybe that are not spiritual and not willing to maybe embrace that pillar, could be, if you're part of a faith-based volunteer group or just a social group, for example, can that fill that need? That I agree, it's a very important pillar in my life. But what are your thoughts for the person who may, and if you are, as you work with the patient, you have to, I can imagine, give some kind of spiritual prescription, and how you go about doing that?
Yeah, this would be the why question. So in the entrepreneur circle, a lot of people ask the why behind the business, the motivation. And that's the same thing with life. I guess you could say it's your trying to prevent your metaphysical crisis, which leads to mental and physical health dysregulation. Yeah. So the other way to think about this is Maslow's hierarchy of needs. It's more of a spiritual homework than it is a spiritual prescription. But if you wait until end of life care, or if you imagine yourself in the hospital dying of a terminal disease, then it is very often, even in individuals that would normally never want to talk to any sort of spiritual person or faith-based organization, they call in a chaplain or whatnot, just to talk because they become very interested in it. And the way I see it is there's no reason to wait until the end of your life, whenever it might be, to ponder this. Whether you believe in a natural intelligence, I think certainly believing in a natural intelligence is a lot more plausible than an artificial intelligence, given that, well, what made the artificial intelligence? Was it a natural intelligence? Or regardless of what you believe, even if you're a nihilist, as long as you're secure in being a nihilist, maybe your only reason for living is because you really enjoy telling people who are spiritual or religious that their way of living is not a good way. As long as you're secure in that, I think that fulfills the need.
Yeah. Good response. Yeah. Yeah. I think just having that purpose, and, I can't imagine personally, like, not being rooted in my Christian faith, and then the Christian philosophy that comes along with that. And, but I mean, I've talked and traveled all over the world and met different cultures, and I feel that, that need is met with a wide variety of different perspectives. And it's opened my mind to just being kind of sheltered in the US for a while before I started traveling. And so it's
There's a
really
lot of
interesting.
tie-ins with social health. Cultures would not be able to progress into civilization without meeting that spiritual need. And at some point, it becomes much harder to focus your physical and mental health when you're constantly worried about
well put.
why I'm here.
Well, Kyle,
or what
thank you
your
so much
purpose in
for
life
sharing
is.
your wisdom, your knowledge, which is like I said, an encyclopedia of information on medicine and many other topics that we could have delved into. But what's the best way for people to access you? I'm sure you're super busy in your practice and also in your podcast. And what things, how can people best get in contact with you and follow you?
My hub is Instagram, Kyle Gillett MD, and my website's Gillett Health, Gillett Health on all other platforms. And we have that new Gillett Health podcast as well.
Well, Kyle, we've had an amazing time going over. Thank you for sharing. I feel like this is super dense information. We hit a lot of topics that I get a lot of questions about through email. We are super excited to have you as a speaker for the Metabolic Health Summit. Thank you for agreeing to do that and for agreeing to share your knowledge on this podcast, Metabolic Link. Thank you. And,
my pleasure. Thank you.
I look forward to seeing you soon in January.